Okay, everybody, I think we'll get started. For our speakers, when you get up here, the mic is very sensitive, so you don't have to be too close to it. And we have a clicker for you, as we showed some of you. Before we get started, I'm going to have Matthew Bowman come up, one of our big-time PTs, and he's going to give a little spiel about our roundtables. And
yeah, but I'm short, so it can't be that big time. Hi, good morning. Thank you for being here, and I won't take too much time from them. I'm sure you're all tired of hearing from me anyways. So the roundtables are next. They start at noon, so about 15 minutes after this. The list of them are in your app, so take a look at those. There's some really great roundtables being discussed this year. So take a look, but pay attention, but take a look. Pay attention, but take a look, figure that out. And they're in 224 and 229. If you're not familiar with that, with the lunch and learns and the roundtables, you can grab lunch. They're small little, almost like focus groups where you're discussing that topic of that roundtable, and the lunch and learn is more of a presentation. But you're not missing lunch if you go. You want you to bring lunch. We want it to be interactive for those roundtables. So please attend them. It is a prepped discussion, but it's facilitated. Everyone can join in. So please, there's some really good topics on PT and RT, and they're in 224 and 229. I didn't keep it under a minute, but I came close.
pretty good. We'll let you slide.
Thanks.
Okay, so welcome everybody. We're very excited about the presenters we have here today. A nice diverse group of presenters from speech, RN, PA, and physical therapy. So I would like to first start by introducing my co-chair, Matthew. Matthew is an assistant director at UCLA Santa Monica. He has 16 years of acute and ambulatory experience, oversees inpatient and ambulatory operations. His focus is quality research and chronic disease management. This is his 11th North American Cystic Fibrosis Conference.
And thank you, Marcin. And I'd like to introduce Marcin Madej. He's a senior physical therapist at NYP Columbia Hospital. He has worked closely with patients with cystic fibrosis at the pediatric and adult CF clinics. He teaches cardiopulmonary classes at Columbia University PT program and has presented at NACFC for over 11 years. His passion is cardiopulmonary and physical therapy in the intensive care unit.
Okay, so we have nothing to disclose. So first, I would like to introduce onto the stage Priggy. Please come up. So we also have a nice diverse group of all over the US here representing Dallas, Texas, Priggy. And then you could choose your slide.
All right. Thank you, Marcin and Matthew, for this time and this invitation. As introduced, my name is Priji Varghese, nurse practitioner, QI lead, as well as program coordinator for the pediatric CF team in Dallas. And this morning, I want to share our QI project on identifying advanced lung disease patients in a pediatric center and how we went about standardizing a transplant referral protocol. Oops.
Let's try it again. On the right click. Yeah.
There, sorry. I have no disclosures. All right, I first of all wanted to start by introducing my team. A few of my team members are here, so thank you guys. We are a pediatric center located in Dallas. We practice at Children's Health, but the providers are employed through UT Southwestern. We have about 273 patients, and only about 245 are in the registry. We have a large multidisciplinary team, as you can see, 7 pulmonary providers, 3 GI providers, 1 endocrinologist, 2 social workers, RDs, RTs, RNs, RCs, and medical assistants, and 1 psychologist, 1 physical therapist, a nurse educator, and genetic counselor. We usually see our patients Monday, Tuesday, Thursday mornings, and whenever else. And then we have 3 joint CFRD clinics a month. So as you can see, we're pretty busy. All right, now let's look at the definition of advanced lung disease in cystic fibrosis. The advanced lung disease guidelines came out in 2020 and is published in the Journal of Cystic Fibrosis. So you guys can reference that. It gives us a threefold definition of advanced lung disease. Forced expiratory volume in 1 second, 40% or less predicted at baseline for an adult, and 50% or less predicted at baseline for a pediatric patient. Or they have been referred for lung transplantation evaluation already, or they have one or more of the following clinical characteristics: previous ICU stay for respiratory failure, hypercarbia, daytime resting oxygen requirement, pulmonary hypertension as evidenced on an echo, severe functional impairment from respiratory distress, and a 6-minute walk test distance of less than 400 meters. Additionally, clinical manifestations associated with worse prognosis should also be considered when flagging your patients as advanced lung disease. Do they have frequent pulmonary exacerbations that they're coming into the hospital? Do they have a rapid rate of decline in their lung function and now it's harder and harder to get them back up to their baseline? Do they have supplemental oxygen requirements with exercise or sleep? Do they have worsening malnutrition despite supplementation with oral or enteral feeds? Do they have infections that are very difficult to manage because of their highly resistant organisms? And do they have CFRD, adding another layer of complexity to their diagnosis? Do they have history of pneumothorax and or a massive hemoptysis requiring ICU stay and embolization? We all know that these manifestations are associated with reduced quality of life, worsening clinical prognosis, as well as increased healthcare utilization. It is also important to know when it is appropriate to discuss transplant. This image was taken from the lung transplant referral guidelines that came out in 2019. As you can see, annual discussion about transplant starts for everyone when FEV1 is at 50% or below. At that time, your goal really is to identify any potential barriers for transplant. Then at 40% of lung function, referral is considered depending on severity of their disease. And then for all patients with lung function under 30%, referral is recommended. And if there are contraindications for transplant, patients should be referred to at least 2 transplant centers before making the final decision. Our initial steps in this QI project was to first review the CFF transplant and ALD guidelines as a team. Then we identified our patients who fit into that category, whose lung functions were 50% or less. Next, we did a process map of how we were actually at the current time referring our patients for transplant. And this is what our initial transplant referral process looked like. We started with talking with the patients and families about transplant referral. Then we would wait and see if the patient and family were ready for referral. And once they notified that they were ready to talk about it and move forward, we would identify potential transplant centers. At our institution, we do not have a lung transplant program, so most of our patients are referred out to Texas Children's in Houston. Transplant centers are also dictated through insurance as well. So then when families were actually ready to initiate that referral process, I would call up the transplant center, get all the information needed for the transplant packet, put all that together, fax or mail it out to Houston, and then just notify the family, hey, I've sent everything off, now just wait for transplant to call you for an appointment. So as you can see, it's a pretty simple process, but we really did not take into consideration any psychosocial aspects, and we never really assessed the readiness of our patients or families. But we felt like we had a really good foundation to build on. When we began this project in 2021, we had 10 patients that fell into the ALD category. Out of the 10, we had 3 who had already been evaluated for transplant, 2 who were not eligible or denied needing a referral. 1 was already transplanted, and we were just seeing her for her CF care. But we realized we had 4 patients that were not referred, and transplant referral wasn't even consistently discussed. So the focus of our QI project was those 4 patients. So our global aim was to identify early advanced lung disease patients and standardize the process for lung transplant referrals. As common in QI, we had many smaller specific aims that led into our global aim. In 2021, we wanted to initiate the ALD checklist on all 4 patients by June, and we were able to achieve that by May. And then we focused on initiating palliative care visits for all 4 patients by December of 2021, and we were also able to achieve that by November. Then we started 2022. We wanted to aim for all 4 patients to have their referral packets sent to transplant centers by the end of the year. And we were able to also achieve that by June 2022. When we started 2023, we actually had one of our patients pass away. So we had 3 patients left, and our focus was to get them all seen at Texas Children's by December of this year. And I'm happy to say we were able to get them all seen by July of this year. And now our focus is on advanced lung disease educational tools for our patients and families. So we aim to submit our first iteration of our document to the HEAL committee, which is our educational committee at our institution, for their approval. So we just actually, last couple of weeks, just received some feedback from them, and I'll be sharing those with you guys. All right, so our interventions really were rather simple, but it did take some time. We started up by writing up a very detailed medical summary on all of our ALD patients, which later would become part of their transplant workup. Then we created an ALD checklist, an ALD registry, and a watcher list. Then we partnered with our palliative care. Now, before this project, we only really saw palliative care in the rare instances we had a patient in the ICU at end-of-life care. So really to partner with them and connect with them was a fantastic intervention. I really feel like palliative care is underutilized in CF care, and they were really excited when we approached them. So I would really encourage you guys after conference, if you haven't met your palliative care department, please connect with them. They have so much resources and insights into chronic disease care. They also were really helpful in meeting our families where they were at, and they would come into our CF clinic to see these patients instead of having another extra visit. They would also work with the family to see if palliative care needs to meet with the patient by themselves or with the families by themselves, or do it as a joint meeting, or do it via telephone call or a telehealth visit. So they've been working really well with our team, and this would be an ongoing commitment and partnership. Then we also partnered intentionally with our psychosocial team. So prior to this QI project, our social worker was really the only other member of the team that was part of this process, only because the social workers had to come up with and write up a social work evaluation for the transplant workup. So with this project, we really wanted to get our psychologist, our child life specialist, our nurse educator, and all of our team, our physical therapist, everyone to kind of help us in this process of identifying any barriers for transplant referral, and also kind of identifying, is this patient really ready to have this conversation? Are these parents ready for this? So we all know this is a very difficult conversation. So I'm really appreciative of our psychosocial team and their insight into this project. It was invaluable and helped us really hone in on different barriers and things to work on with our patients. All right, so as mentioned before, one of our interventions was an ALD checklist. Now, this is a really simple Word document that we created. We referenced the guidelines as well as the ALD section in Port CF. And I know we talked about ALD section just recently at the registry luncheon yesterday. CF Foundation does have a clinical care guidelines for advanced lung disease. So we referenced all of it and just kind of tweaked it to fit our vision and goal for our project. So at minimum, we aim to get a 6-minute walk, a VBG, an echo, and a referral to physical therapy. And if we were able to, additionally, we would like to get a body box, sleep study, a pulse-ox study, a hearing test for toxicity, nephrology consult to evaluate for chronic kidney disease, a formal care conference between the team as well as the patient and family, and of course, a palliative care consult. Now, of course, as outpatient, we're not able to get all of this done ourselves. So I created a smart phrase using the checklist. So the checklist was just turned into a smart phrase that we would put into Epic and into our notes. And so, of course, when most of our ALD patients are our frequent flyers, so when they would come in to be admitted, inpatient was able to view this checklist and the outpatient notes, and they were able to see what was already done, what was needed. And so they would aim to try to get all of this additional items done during that admission or like towards the end of the admission. So we were able to get all of this done on all of our ALD patients during admission. We also then decided to take that ALD checklist and kind of squeeze it into our patient review sheet. This is our weekly patient review that we do as a team for patients coming in the following week. So as you can see, we put it into that middle section, kind of squeezed it in there. But this really just kind of helped us as a team plan their visits better, because we really wanted to either talk about, order, or get done one of these items on this checklist. So it just helped us plan better for their visits. All right, so this is the ALD registry that I came up with. Again, just a simple spreadsheet that I keep up with. So it has their names, their recent lung function, transplant status, and then all the items from the ALD checklist I put on here. And so as soon as it gets done, I just update this. And then this is what I then give to my registry coordinator at the end of the year, so she can input all this information into the ALD section in Port CF. So while we were creating our patient list for ALD, one of my nurses, Kate, had the greatest idea of having a watcher list. So this is the list of patients who could potentially scoot into that advanced lung disease category at a sooner and faster rate. So their lung functions may not be at, 50% or anything, but they had comorbidities that could potentially move them faster. And so this is just a separate spreadsheet. I look at their recent lung function and then comorbidities like CFRD, hemoptysis, and then like frequent exacerbations or liver disease, all of the other things that we were looking at. One of the things that we did add was modulator eligibility. And this is our current list. And as you can see, half of our patients on this watcher list are not eligible for a modulator. So now I wanted to share with you guys feedback from our patients and family, because as a team, we saw that this new process worked really well for us, but we really wanted to get the feedback from our patients because they're our customers. And so they're also experiencing this process alongside us. And so a few of our patients said it was really nice to talk without my mom. It took a few days for me to see everyone. So this was a really good feedback for me, because I was like, oh, did we not mention to you it wasn't just a one-day thing? Because transplant evaluations are a full week ordeal. It's about 3 to 5 days in Houston that they would have to drive up or fly up there and stay in a hotel and attend all of these appointments. And so it was really good for us to kind of say, oh, if we did mention it, we need to probably mention it again. Then one patient said everything went well. They knew all about me. From a family standpoint, thank you for the explanation. One of the moms said she was really grateful, especially for the evaluation, what to expect when they got to Houston. And then one mom said it would be nice to have the schedule of appointments weeks in advance. And I really think Houston does a really great job of sending out the list of all the appointments. But understandably, this mom was very anxious and she just wanted it a little bit sooner. And then, of course, one family said it was really hard to have 2 kids doing this at the same time. And everything went well. We enjoyed meeting the transplant team. So all of these feedbacks were communicated to my team as well as to Houston. All right, so as mentioned before, part of our project was also to assess readiness of patients and families for transplant. And at this time, we never really had any information or educational materials to pass out. Now, CFF has a great lung transplant educational materials that's available. And then Houston also had pre-transplant information that they sent to us. So everything was a little bit overwhelming for us to look at. But we referenced all of it and sort of came up with a document that worked well for us. And this document was done as a multidisciplinary team, but also with the help of our parent partner, Tracy Liberto. So having a parent on this QI team is fantastic because she gave us insight into, oh, this is what I want to know about. This is what should be on that document. So this is our first draft, and this is what we actually submitted to HEAL committee, and they came back and told us this is too wordy, and this is way over the 6th grade reading level. And one of the good things that they mentioned was that there's actually 2 concepts on this document, a lung transplant referral and the evaluation, and they asked us to separate those 2 topics into 2 different documents. So we're in the process of tweaking that. But they also said, as a children's hospital, we love pictures and icons and images. And they were like, there's none on here. And so they wanted us to sort of do a visual pathway. And so that's what we hurriedly did last week, kind of put this together real quick, a lung transplant referral journey map. So again, this is visually appealing for pediatric patients, also for adults, right? So very easy to kind of follow through, talk about transplant early, referral to the transplant center, evaluation by the transplant center, review your case by transplant team, and then a decision regarding transplant, whether you get listed or you are not a candidate. And then behind this, so this will be a front and back document, we'll have the icons and then all the action items listed underneath that. So hopefully this will be approved by our HEAL committee. I really like this idea better. So our goal is after conference, when we get a minute, we'll redo this and make it a little bit more better and resubmit it back to the HEAL committee for approval. So this is our most up-to-date process map on referral. As you can see, it has evolved from where we started in 2021. And all the highlighted boxes are the new steps that were added that came out of this QI project. So initiating our ALD checklist, handing out transplant educational materials, having the team, having the patient meet with the psychosocial team, our psychologist, our PT, our palliative care, everyone. But also on here, we added a decision point regarding Trikafta. So while we were working on this project was when most of our kiddos were getting started on Trikafta, and parents really wanted to hold off and see what Trikafta would do before stepping forward through, referral. And so we added that to say, hey, let's look at patients, evaluate them at 6 months of being on Trikafta and again at a year of being on Trikafta and see what it did. And of course, we are all familiar that, ALD patients don't have that robust lung function increase as most of the other patients have seen. In fact, our patients went up maybe 1 or 2%, but overall they were just stable at where they were at. And then this process ends with obviously us following up with transplant and making sure that, hey, Houston, do y'all need anything else from us? Are you having trouble reaching this family for an appointment? So all of these things came out of this project. And then having our child life specialists really take time to meet with the patient individually and as a family prior to that first initial visit in Houston. So in conclusion, we have come a long way in this project and have standardized our referral process. Our next steps include to continue to update our ALD registry, initiate ALD checklist annually on all of our patients, monitor our watcher list, and then continue communications with Texas Children's regarding follow-up. So currently, all 3 patients that we're seeing, they're stable and not listed. And so Houston just wanted to see them in a year, and then if anything clinically changes, they'll see them sooner. And then obviously to finalize our educational tool so that we can have something that we can hand off to our patients earlier in this process. And then of course, no QI is complete till it's written up. So we want to really work towards a manuscript. And that's it. I'll take some questions now.
Any questions? Please use the mic. You want to come up to the mic? Okay. Or projects.
I will help that. So my question is with, I know you mentioned.
Oh, you know what? We have remote. Yeah, we have remote if you can use the mic. Sorry. Thank you.
Because it's on Sorry. I was wondering with like adults, I mean, I know you guys are all working with pediatrics, but have you had any experience with adults that were referred when they, were getting ready, they thought they were getting ready for transplant, but started Trikafta and started like just being very stable for years and years. And I'm wondering how the transplant centers approach that. Like if they, see them every year instead of 6 months, or if they want to see them more often. I think a lot of transplant centers are getting used to patients with low lung function, but that are very stable, maybe not improving.
Yes.
I was just wondering if that changes like the trajectory of when the process starts.
That's a really great question. So I can't speak to adults, but we did have a patient, I want to say she is now 12. So Trikafta actually was started as a compassionate use for her prior to her age group being approved. And her lung functions were 40s to 50s before Trikafta started. And for her specifically, it has really gone up now to 60s and 70s. And she continues to have CFRD and all of the other comorbidities, but very stable in her lung function. And so when we reached out to Houston, they were like, okay, well, we'll see her in a year, and just make sure she's pretty stable, or, we'll see her even via telehealth or anything, like in 6 months, if they have any sort of decline in lung function or anything else that pops up. So we've really just taken her off of our, ALD and put her on our watcher list for now. But that's a really great point. Thank you.
Thanks so much. I love the creation of your journey map and your watcher lists. Did you try to automate the ALD registry you created at all and try to take some of that work off your plate?
So we, I mean, it's not a lot of patients that we have, right? So we are in the process of trying to automate that. I don't think right now, the journey map is actually through the educational department, so they have a template that we use. So we're not able to kind of automate registry information into that just yet, but that's something that we can definitely look into. Oh, someone sneezing.
Hey, great talk. I was wondering who in your clinic is in charge of initiating the ADL checklist that y'all do on an annual basis?
Myself. No, I think we work as a team. So we all as a team, since we don't have that many patients that fall into that category, so the whole team is aware of who our ALD patients are. So and again, we use that ALD checklist in our patient review. So when these patients are coming as a team, we'll know, hey, this is done or this is not done. And so I think it's a group effort to kind of remind. But as the provider seeing that patient in clinic, I definitely pull up the checklist and review it with the patient and parent in the room and say, hey, next time you come, let's try to talk about getting an echo scheduled and things like that. So I think it's a group effort, but more so during clinic visits directed by the provider seeing them.
Thank you.
You're welcome.
Thank you, Tracy. And then I think you had a couple more through the app, but we'll wait to the end to make sure we have time for everybody. Okay, next I would like to welcome Abe Sender. Abe was born in central New York and moved to Vermont in 2001 to attend the University of Vermont, where he earned a bachelor's degree in sociology. He subsequently earned his MSPA for the University of New England in 2008, and he worked in family practice in Maine for 2 years before moving back to Vermont to work in pulmonary medicine at the University of Vermont Medical Center. He's been working in the CF population since 2010, focusing on clinical care and research. Abe is a partnership enhancement facilitator and a professional mentor for LEAP and the CF Foundation Advanced Practice Provider Fellowship Program. He lives in Vermont with his wife and 2 children. In his free time, Abe enjoys rock climbing, hiking, skiing, and spending time with his family. And you know what? We didn't actually introduce Pridgie first, so we forget. But Pridgie Verghese received her Bachelor of Science in Nursing in 2004. Her Master of Science in Nursing in 2010 from Texas Women's University in Dallas. She has been a nurse practitioner with the Pediatric CF Center at Children's Health since 2014. She assumed her role in the CF Program Coordinator in 2015. She's also the QI Coordinator for the CF team and is involved in various QI initiatives through the CF Foundation and CF Learning Network. This has given her multiple opportunities to participate both oral poster presentations in QI. And as 2022, she's also a board member of the local CF North Texas chapter in Dallas. And she participated in the 101 QI class too. And if you have an opportunity to do that ever, it's fantastic. But now back to the man, Abe. So please welcome Abe Sender. And Abe, we'll start you here. And then if you want the clicker, it's here. And then, but other than that, you can just use the arrows.
All right, well, thank you. Good morning, I'm Abe Sender. I'm a physician assistant with the adult program in Burlington, Vermont. And just a thank you to the NACFC Planning Committee session chairs for the opportunity to talk to you all today. I'm presenting a QI project similarly on an early transplant education intervention with a focus on social emotional readiness. I have no pertinent disclosures. So as way of background, who are we? At the University of Vermont Medical Center, we're a small rural area. We have about 100 patients in our catchment, and patients will travel up to 4 hours or so to see us. So what is this project? We're looking to improve outcomes for people with CF who also have advanced lung disease. This came from working in the CF LTT LLC3, or the Lung Transplant Transition Leadership Learning Collaborative, lung transplant, a lot of letters. and basically partnering with we also don't have a transplant center, so referral center partnering with a transplant center. We partnered with MGH and did a combined project, and we did an individual project, and this is our individual center project from that collaborative. So why? In 2019, the guidelines paper was published with the recommendation for pre-transplant conversations for everyone with an FEV1 below 50% predicted in the adult world. We did not have a systematic approach. We were having conversations with lots of people. We weren't necessarily documenting them. But in folks who had gone through transplant already, we identified this gap in pre-transplant social emotional readiness. That was sort of done informally with conversations between patients and family members, with members of our team, our social worker, our psychologist, et cetera. So what is social emotional readiness? There's no solidly agreed upon definition. It comes out of childhood education research, but it incorporates these 5 core elements: self-awareness, self-management, social awareness, relationship skills, and making responsible decisions. For our project, we focused on these core elements for a couple of purposes. We wanted to educate our population by providing detailed and digestible information to kind of prepare them for the very significant journey that is entering into lung transplant. But we also really wanted to empower folks to kind of pursue their individualized goals and plans to work on their own readiness, encouraging them to draw from and expand on their own sort of personal skill sets. So methods, we developed an educational packet with a focus on increasing knowledge and self-efficacy. And for this, we define self-efficacy as an individual's belief in their capacity to execute certain behaviors. We leveraged CF SMART reports to identify anyone within our population with an FEV1 below 50% predicted. Then we would introduce the project by a provider during a clinic visit, and a pre-education self-efficacy survey was completed. And once that was done, the educational packet was introduced and briefly gone over or reviewed. So this is our kind of baseline characteristics table. We initially identified 15 folks with FEV1s below 50% predicted. 2 were excluded. 1 was someone who had very advanced lung disease, had previously opted not to pursue transplant, was kind of on a end-of-life trajectory with palliative care involved already. And the other was an elderly woman who had progressive dementia, and so it didn't seem appropriate. So we ended up identifying 13 eligible patients, and over the course of the project, 2 actually came out. 1 because they were transplanted successfully, and the other, her FEV1 improved out of this, out of eligibility, which is great. Of note, we did have 1 patient undergo transplant during this period of time who didn't qualify. Their FEV1 was higher. They had a lower FEV1 historically and had a really robust response to ETI, but ended up with pretty significant massive hemoptysis prompting an urgent transplant. So our packet is pretty big. This is a snip of it. This is our table of contents. Anything you see here in bold were sections within the packet that we would have individual conversations with. This was a very multidisciplinary project. From conception of project to designing the approach and the rollout to writing the educational materials and reviewing it. We had patient involvement fully incorporated, someone, an adult patient with CF and advanced lung disease who sat in on all of our meetings. And we worked really closely with our team psychologist to sort of identify exactly our strategy for self-efficacy and social emotional readiness, how to look at that and measure it. 3 of these sections were kind of, the conversations were administered or involved the providers, and those were frequently asked questions, first appointment, and alternatives to transplant. Medication behaviors was, medication changes was done by Martine Antel, our pharmacist. Healthy Behaviors by Kitty Brady, our respiratory therapist. Caregiver Support by Christine Pryor, our social worker. Nutritional Information by Marianne Ludlow, our dietitian. And then the Emotional and Behavioral Health one was done either in person in a clinic visit or at a separate visit with our psychologist, by our team psychologist, Tara McCune, which was really, really, really helpful. So again, the process, we would introduce the project, and the pre-education self-efficacy survey would be filled out. And then we would go through this table of contents and have folks self-identify the pace and order that they were interested in engaging in this work. And then we would, for each clinic visit, we would identify folks in pre-visit screening. Our program coordinator, who is also our social worker, does a lot of the pre-visit screening, and she would identify folks who were in the project and what they had selected for their next sort of section. And she would send an email to them as a reminder, hey, come with questions, go over this information, we're gonna be talking about it. And then the care team member would prepare on their end, and we would, as part of the clinic visit, we'd have an in-clinic conversation surrounding that particular topic or those topics. After each one of these sections, a post-education knowledge questionnaire was completed. And then when each of these sections is completed, we would repeat a post-intervention self-efficacy survey. So here's the run chart of our results. Q4 of 2021, when we started, we were documenting none of these conversations. We were having some of them, but there was no systematic approach, and we weren't necessarily documenting them. With this program, we got up to 100% of folks who are eligible having a documented conversation. That's great. We feel really good about it, but it does feel a bit of a bottom of the barrel measure. We didn't want to have just a single conversation. We wanted to have robust, repeated conversations to really help prepare folks. So here is our self-efficacy survey, and the scores are the aggregate of the pre-survey results for our folks. So like I said, our goal was to have a much more robust, ongoing, meaningful conversation with them. And as a result of that, I mean, initially I think we thought higher scores is better. As we got into it more and we started thinking about it more, maybe the goal is just to move the number. Maybe it's just to get people thinking. The more folks know about the transplant process may not make them more confident in their ability to do it, but they may understand it better. It may help them prepare better. So more on that later. Kind of as an example of this, we had a new diagnosis who was in his 50s, had been through a lot of health things and a lot of health concerns in his life. He was at the time unhoused, smoking, concomitant COPD. And when he filled this out, he gave himself 10 out of 10s on every single one of them. And we love his energy. Not sure we share his confidence, but it's a tool to get this conversation started, which is great. So here's completed data. We only have had one of the 13 people complete data. That's because this is a really long process. Most of our patients are being seen quarterly. The one person who has completed data has advanced NTM disease and comes to clinic monthly. So we just had a lot more touch points with her. So interestingly, you can see there were several measures that didn't move, but there were two measures that the numbers went up and two that the numbers went down. I don't want to say improved because, again, we're not sure exactly what the change in numbers means yet. So in the areas where scores improved, they were how confident do you feel you can keep the emotional distress caused by your disease from interfering with the transplant process? And how confident do you feel that you can secure the psychosocial support needed to identify two caregivers? Interestingly, she was someone who went through transplant evaluation in the middle of this process. So it's a little bit hard to separate how much the educational packet changed her perception of this and how much going through the process with her family members affected that. But either way, I feel really great about question 8, how she improved. She really feels confident that she can have that. And that was her biggest barrier to start with, which is great. So I didn't say before, but the self-efficacy questionnaire was modified from a 6-point self-efficacy questionnaire for general chronic disease management. And there's not really a minimal meaningful change that I've found yet in the literature. So that would be really nice to have, and we will continue to kind of look at that. In terms of the scores that reduced, they were both on this confidence and ability to honestly discuss wishes related to transplant and or end-of-life care with either care team or friends and family. And I was able to, have kind of a post conversation with this patient. And she really felt like a lot of the information behind that question 7 piece, the friends and family, just had to do with interpersonal family dynamics with her particular psychosocial situation. So conclusions, there definitely are struggles with metrics, which I've alluded to here, and we're not sure what success looks like, but we are having those conversations. We did initially anticipate lower self-efficacy scores that would improve with the education. We're considering broadening eligibility criteria to include folks with a history of massive hemoptysis, recurrent pneumothorax, and people with kind of aggressive infection, chronic NTM disease, sepasias, et cetera. It was largely really well received by our patients. We got a lot of folks who were really pleased to have this information, and there were 2 big take homes I felt like in talking with folks. They felt like having a systematic approach to discussing this and bringing transplant up made it so much more approachable to them. They felt like, okay, you're doing this with everyone at a certain cutoff point. So you're not targeting me and telling me that I'm in trouble clinically, made them able to sort of engage in the information and not as fearful. And it also, for a lot of our folks who are really, really type A and they're doers, it felt really nice to have a process to prepare. They felt like they could do something that could give them some agency and ownership over preparing for this process. So in terms of barriers and limitation, on the patient level, certainly last minute changes in scheduling are tough. We are a small center. We have one of each of these, one person who is in each of these subspecialties within the care teams. And so if they move and our nutritionist is on vacation, that it's just not happening that week. And then it's 3 months before we can do that. So that's definitely something we have to explore more. We see maladaptive coping and people trying to avoid conversations for sure. People who come not prepared, they haven't pre-read the packet. We're not going to present it to them. We're going to have conversations with them and answer questions so we can tailor our education strategies towards their needs. On a system level, we have 3 adult providers who share the patients. So there's a variability in providers. There's definitely competing interests if folks are sick or other things are going on. And then if our coordinator is on vacation, chart prep doesn't happen. And so we gotta offload that and figure out how to back her up for sure. She's overworking. So next steps. We want to complete data collection. We're hoping to get that done in the next, hopefully 12 months. Analyze data. We're going to have to come up with more of a qualitative lens to how to interpret this data and continued scholarship publication. I'd like to acknowledge our team, awesome team to work with. I feel really lucky to work with this group of people who've put together this really robust educational packet. Thank you to our coaches through the LTTL LC3, the NACFC Planning Committee session chairs. I appreciate it. And with that, I will take questions.
Thank you so much. Any questions?
I am Donna from Rochester, New York. For your education, how did you determine what to put in that education? Did you elicit some responses from patients first, or did you guys sort of as a team decide what you wanted patients to be most educated about, or how did that happen?
Yeah, that's a great question. Thank you. So we worked as a team. We had, like I said, a fully incorporated patient who had been through the transplant referral process already. And so kind of had some experience with that. We looked at guidelines papers, the CF Foundation statement. And I believe we worked with our MGH partners as well. Like, what are folks coming to you guys not ready for? Because we had the luxury of being involved in this combined project. And then each section that's administered by an individual care team member was written by that care team member. And then we have weekly QI meetings where different iterations of this would come back. We'd group edit, which was painful, but worth it. Maybe. My team may disagree. And we just slowly refined it. And I think it's a good point. It's one of the things, we may have to continue to refine. One thing I didn't include, in having post-conversation with our one patient who completed it, one really interesting piece of feedback she gave us was definitely broaden your criteria. Offer this to everyone, regardless of how far along their disease is. Maybe they're a young adult who's looking to go to grad school, and this is gonna make them realize that having to travel 3 hours or 6 hours to go to a transplant center is not desirable, and maybe they should look at cities where transplant centers exist. That didn't cross my mind. So I think we're thinking about what it looks like to incorporate this more holistically in our practice. So.
I love the utilization of your confidence score as well, because it can spark a conversation. If you're a 6 or 7, what would it take you to get to an 8 or 9? So
Totally motivational interviewing.
yeah, we have something similar for our pulmonary navigator and chronic disease patients, and it is funny how many people will say 10, and then you say, "What are your medications?" I don't know.
Right.
So,
Totally.
thank you so much, Abe.
Okay, thank you so much. So next, I would like to introduce Ayin Ong and Veronica Downer with a live speaker that will be joining us, Megan. Adult Cystic Fibrosis Center. Megan is joining us from her home in Michigan as she is the team's patient representative. Ayin is the team's dietitian, and Ronnie is the CF clinical nurse. established their QI team in 2018 and have participated in several of the VIP programs throughout the CF Foundation, as well as the RDN. So I would like to introduce Ayin and Veronica.
And then,
Yeah, right here. Look at this one. Yeah. And then just say start. Yes.
okay. Well, thank you for the opportunity for us to be here today. Our talk is on our center's initiative to improve patient understanding of lung transplantation processes. We have no relationship to disclose related to this presentation. Lung transplantation is a critical option for people with CF who have advanced lung disease. The lung transplant guidelines clearly highlight the importance of education and timely referral to ensure patients have the opportunity to learn about the process and criteria. As part of our quality improvement project, we decided to look at our center's process, and through that, we realized that there is definitely significant room for improvement. We discovered that when patients' FEV1 were nearing transplant referral, many of them had never had a conversations with their care team member. Lack of education contributed to anxiety at the time of referral. At the time of preparing this presentation, well, we are a fairly big center. We have about 369 patients who have not received lung transplant, and 307 adults have an FEV1 of 50% and above, 34 adults with an FEV1 between 40 and 49, and 28 with an FEV1 less than 40%. Our goal was to ensure all patients are receiving lung transplant education annually in a standardized process. We also believe that in order to reduce the anxiety our patient had regarding lung transplant, routine education will help normalize the discussions and minimize the fear of the topic. We hypothesize that our transplant education will improve understanding of referral criteria while simultaneously reducing anxiety about the process. So when patients schedule for clinic each week, our RT help to review who is eligible for education using electronic medical record and transplant education tracker. We knew that carving out time within a clinic appointment to provide education would be a challenge and decided to create this dyad between nursing and physicians. It was important to us to make sure that patients nearing transplant referral were educated by their CF physicians, and those with higher lung functioning were not unnecessarily alarmed by that their physician is discussing lung transplant with them. While the extreme were easy, it was Megan, our patient's advisor, who led the charge to pinpoint at what point in the patient's trajectory that the education should be provided by a physician rather than a nurse. As we refer patients for lung transplant at FEV1 of 40%, 50% allow for patients to have multiple conversations with their physicians before referral. As we see patients in person and virtually, we want to make sure to utilize both of these platforms and try to educate as many patients as possible. We exclude patients who had already received lung transplant and those who had already been referred and actively meeting with the transplant team. While our goal is to make sure everyone is receiving education, we do feel that doing it during pregnancy would inherently create more anxiety, so we would defer that until after delivery. Pre and post survey were developed to assess lung transplant knowledge and attitude. Pre-survey were administered just prior to the initial education, and the post-survey were administered at a follow-up visit. Survey were distributed and collected anonymously by any care team member who are not providing education. For knowledge assessment, patients were asked to list 2 of the 4 criteria for transplant referral, both pre and post. Our survey also addressed whether the educating process increased their anxiety. This is just a quick look at our clinic board that we use. We just add a pre and post survey columns just so that we can, track and collect the survey.
It was important that the patient population the RN provided education to were people with stable lung functioning that would not be in need of a transplant in the near future. Our group defined these patients as those with FEV1 that was equal or greater to 50% lung function. Around the time we were working on the QI project, we had an increase in nursing FTE, which was imperative to being able for nursing to have the available time to provide education in the clinic. When nursing meets with patients, we provide education about the transplant guidelines and try and normalize that we're providing this education to everybody. We make sure to reinforce that in order to have the best chance of success with lung transplant, we refer early so that if there are any medical or psychosocial barriers, that we can help work on these prior to being medically in need of new lungs. We focus on the primary factors that lead us to refer somebody to the lung transplant, such as FEV1 less than 40% on a consistent basis, increased oxygen use, IV antibiotic use 3 to 4 times a year, whether at home or in the hospital, and CO2 retention. Nursing makes sure to explain that it is all of these factors, not just one factor, that determines when the patient should be referred to lung transplant. Our QI team created an education pamphlet that was approved by our institution's clearinghouse so that we can provide a hard copy or a virtual copy to the folks so that they can have a copy of the information. Additionally, we provide links to U of M's transplant program website and the CF Foundation's lung transplant guidelines. For our patients that have FEV1 less than 50%, the physician provides the education. While the education is similar to what nursing is teaching, the provider goes into more specific detail and tailors it to the patient and their health status. If there are any barriers that have been identified, the MD will go over this in detail, along with how we can work together to try and modify the barrier. The discussion focuses on when it is time to place a referral to the transplant team and what the timeline would look like. This discussion happens annually and more frequently depending on the lung function and the clinical status. The physician stresses the importance of early referral so patients have time to meet and build rapport with their transplant teams, emphasizing that they are the experts at when it is time to be worked up or listed. This is a basic timeline of our QI team's transplant education. We began this QI project in 2019 after the transplant guidelines were published. We first created a process map as well as an educational tool that was reviewed by our education committee. Our rollout of patient education was impeded by the COVID pandemic, but we next generated specific aims for our transplant QI work. To assess the impact of our education project, we generated the previously mentioned pre and post education surveys. In February of this year, we began systematic education of our patients with assessments of their knowledge and anxiety levels. And they should be getting Megan on now.
Is percent of eligible patients, and the x-axis is the month of the year. We captured about 50% of patients at each in-person or virtual clinic visit. This graph captures the number of patients who were educated from February 2023 until August of 2023. We had a total of 146 educated patients, and we missed about 90% of patients at their clinical appointments. It should be we hit about 50% of the patients at the clinical appointment. 127 of those patients had an FEV1 equal to or above 50%. 19 of them had an FEV1 of less than 50%. In most months, we were able to provide education to about 50% of patients who were in attendance in either virtual or clinic appointments. Here we have the pre-survey results of the transplant education. On the first graph on the left, the y-axis shows the percent of patients, and the x-axis is the reply of yes or no. We specifically measured if the patient had previously received transplant education from their care team prior to February 2023, either due to their specific health needs or through previous education PDSA cycles. Out of 111 surveyed, only 40% of patients reported that they had previously received transplant education from their team. Moving to the graph on the right, the y-axis shows the percent of staff who educated, and the x-axis shows which staff provided the education. We measured who had the transplant conversation with the patient. 20% were educated by the registered nurse, 30% were registered by social work, and about 43% were educated by their physician. There is a small other category, which could be that the patient searched for information about lung transplant online, in social media groups, or in other formats. The graph on this slide measures the patient's anxiety levels around transplant. The y-axis is measured in percent of patients, and the x-axis is measuring where they fall between strongly disagree and strongly agree. We have perceived transplant discussions induce anxiety, and we wanted to specifically measure the burden of talking to the patients, the burden of talking about transplant, and how it impacts our patients' mental health. On the pre-education survey, close to 30% of patients said they strongly agree that talking about transplant increased anxiety. We remeasured the anxiety levels after talking with them about transplant, and those who answered strongly agree dropped to about 10% of patients. This supports our theory that transplant education can help reduce patients' anxiety. We surveyed our patients to assess their knowledge on criteria for transplant referral. Before we educated them, we were strict on what we would accept as correct answers, such as FEV1 less than 40% or equal to, as opposed to someone who said low PFTs. The bottom chart shows a subset of the most common answers our patients gave us. Pre-survey, less than 15% of our patients could identify a correct answer. Once we provided education to our patients about the transplant referral process, we resurveyed them at one of their following clinic appointments using the same criteria. Post-survey, we saw a slight increase in correct answers, but still quite a bit of room for improvement. This supports our theory that most patients do not understand what makes them eligible for being referred to a double lung transplant, and more education is definitely needed. Here are our conclusions. Having educated approximately 60% of patients per visit over 7 months, we found the following barriers. The pandemic required a change in process of education. We had personnel limitations and time constraints. We realized two nurses staffing the clinic was necessary for provisions of education. Assessing outcomes with surveys required a dedicated person to collect and tabulate data. We've learned that education helped decrease anxiety about the transplant process, that pre-education knowledge of specific lung transplant referral criteria is limited, and that the education process improved understanding of criteria for lung transplant. We are continuing to provide first-time education to patients who have not received any, with the plan to provide our second education cycle in February. We are continuing to assess with post-surveys whether yearly education results in improved understanding of the process and further reduces anxiety. Thank you again for for this opportunity to present to the NACFC, and please come visit us at poster number 682. At the end, we also included one other slide. So I've had advanced lung disease for over 10 years. I've been through this entire process from the transplant education by my physician to receiving a double lung transplant on February 27th, 2023. So I'm just over 8 months. These photos actually show my journey after lung transplant. The first photo is about 3 days after my transplant when the ventilator was taken out. This was my first shower after transplant with my adorable waterless shampoo cap. The second photo is 4 days after my transplant, and all I wanted to do was get up and walk. And immediately walking felt amazing. All I wanted to do was walk, even with broken ribs, my chest recently cracked open, chest tubes and drains and lines coming from everywhere. I could immediately feel how easy it was to breathe. I originally agreed to join this QI project 3 years ago in 2020 because the first time I was told about transplant, I just lost it. My FEV1 was already under 40%, and the conversation was, I'm referring you to the transplant clinic. It was never mentioned previously by my care team, which threw me for a loop. I also worked at the University of Michigan in another department during this time, so I always went to the clinic with my badge on. And during my appointment, I put on my I'm okay face and totally fine with this plan. But then as soon as I checked out of clinic, I was sobbing uncontrollably in the hallway of our hospital, forgetting I had my badge on and just blubbering, losing my mind. I actually had staff members pausing to ask if I was okay. So not only was I thoroughly embarrassed that I was sobbing in the hallway, I was also extremely thrown off by this conversation. I decided it was time to just leave work and just go home and, work will still be there tomorrow. And I pretty much sobbed the entire way home. So looking back at that, I thought I was being referred to transplant because honestly, I thought I was going to die soon. I thought if I didn't get my transplant soon, that I thought I would miss my chance. Because that wasn't explained to me. So looking back now, it's been almost 10 years since I was first referred to transplant. But at that point, I just didn't know. So it made me realize that the change needs to happen in the way we explain this to our patients and how we present this material to them. Before transplant, obviously, my 2-year-old nephew knew how to turn my oxygen on when I said I needed oxygen. And my 1-year-old nephew, God bless him, used my oxygen cord as a teeter. So hopefully that's kind of food safe. We'll see. I wasn't able to run around with them or lift them for longer than a minute or two because I get short of breath. Now I can run with them in the backyard, chase after them playing games, and lift them and snuggle until my heart's content or until they beg me to let them down. My husband and I have now been hiking in multiple state parks, going on vacation with our RV, glass hunting on the beach, and while my legs get tired, my breath is totally fine and going strong. We were also able to adopt a sweet little puppy, which you see in pictures 3 and 4, and she's been the best little thing ever. So while I didn't really know how much I struggled over the last 10 years having advanced lung disease and on oxygen, as I was still working up until the day I received the call for the new lungs, I know now how much I'm able to live post-transplant. So from the bottom of my heart, thank you to all of you and every single one of you for all the work that you do. And it's completely because of you and your hard work and dedication that I'm able to thrive and have another opportunity to live my life to the fullest. So thank you. I love you all. And do you guys have any questions for us?
Any questions at this time? We have one coming to the mic.
I want to commend you on the nice presentation, and especially Megan for sharing, all that information in a very personal, way. So I appreciate what you're doing. So I have a few questions. So one is, how did you make, your medical center to provide extra nursing staff for educating people that are far away from transplant? Let's face it, people over 50%, they're far away from transplant. So that's one question.
Okay, so we had been working, I think, short for a long time, and we had some pretty advanced people that were working in there, so we were able to get the work done. But then during one of our site visits, we did have the people that the foundation sent down talk to our higher people up, using those guidelines that the CF Foundation has for how many nurses, but also the fact that you are presenting nationally for QI, and it makes U of M look good, right? Like, we look good, and we are one of the top centers. We try really, really hard. We really feel like we're always behind, and we've just got so much more to do. And with Megan, it just made it so much different because we knew her for a long time, and to have her on this team and stopping us and making us think about things that we wouldn't thought about because it's not us living it, has made it absolutely incredible.
And then the second part is a little more targeted. So you went after, people that have an FEV1 of over 50%, which is good, but truthfully, especially in the modifier era, this is probably a group of people that might not immediately be needed, but there's still a lot of people missing on the less than 50%. And one of the questions is, who are these people? And are they people, that there is a small percentage which are a tough nut to crack, which basically even mention, the word transplant, they refuse, and they are the ones that need it, or the people that don't show up. They show up once every year, basically, and they're the ones that are high risk. So do you have any insights about that specific group and who was missed? Because it's great to educate everybody. The question is, how do we miss the ones that are really high risk, especially nowadays?
The ones that we can't get to go to clinic, if we can get them on a video, what's really getting people to come to clinic is Trikafta, because you have to be seen at least once a year in person and get your labs, or you won't get this drug.
Still, those are the people that, probably there's too much, in there. They're the ones that will never show up again, so you won't have.
Everybody, we have all kinds of different patients. Nobody wants to learn about this. Nobody wants to learn about this. And the first thing that I say when I go in this room is, you don't need a transplant. And then when you're explaining to patients and you're going through the things that get you to go there, I remind them, none of this is in your wheelhouse, and it's all four things, not just one. And it's truly these patients that are educated, and we can't stop educating because somebody's scared.
No.
It's ridiculous.
I agree with you. The problem
And so this first year is not as easy because it's not easy to normalize this. Some of the comments, some people are like, why are you even teaching me this? Like, I'm just trying to live and not worry about my health. But education is power, and we have got to do this for our patients. And we should have been doing this a long, long time ago. People are so fearful, and these people that I talk to, even at greater than 50%, like, they had no clue, right? They're just waiting for that day they come in and the doc's like, it's you. So.
Thank you.
Hi, Joe Paluski from Pittsburgh. I just want to congratulate you on an absolutely fantastic quality improvement project. This is implementation of the referral guidelines to the nth degree. So congratulations to you and your team. I just had a question. One of the feedback pieces I get from the transplant providers at times is, why are you referring this patient too early? And I wondered, Megan, it was great to hear your story. I just wondered, do any of you have any perceptions or comments about what sorts of negative feedback you got other than the denial issue? And to say, what are the downsides of early referral? Have you come across any other than the initial emotional shock?
So, I think more of our problem right now is not all these people we're sending need to have the entire full workup. A lot of people, it's education. So we're actually coming up with a new consult because the orders are to transplant. And when you hit that order, it enacts a ton of other orders. But we're working on getting one that is for education only. And we tell them it's for education. And when I'm teaching them, I'm like, you're going to go meet them. These are the things they're going to do. And they're probably going to tell you, you're too good. We'll talk to you in 6 months or a year. But you're developing relationships. They need to know they can take that chance on you because there's not a lot of lungs.
We're setting a great example for how this should be done well. So again, congratulations. Megan, do you have any thoughts from your perspective? You went 10 years, it sounds like, in between your initial referral and transplant, which I think is perfect, frankly, from my experience. But I wondered what your thoughts were about that.
Yeah, so I think what benefits me is I'm super stubborn. So even if you tell me something, like I will try to do everything to at least push it off for as long as I can. So even during that 10 years, like I still worked full time. I still did all my treatments. It also helps that my mom was a nurse. So she would kick my behind if I even attempted to not do something. So that was definitely a motivator. But I think a lot of it is, it's a hard conversation, absolutely, to have. And how it came to me was a little traumatic. And I think we can make it easier for patients. And I do think referring earlier is better because at least gets the conversation going. Like the patients, they don't understand what a barrier is to transplant if they haven't seen transplant, like even if it's just, don't smoke or you have to stop drinking or whatever it is. I mean, earlier is better to prepare yourself. And I met with Dr. Sagana before I was listed probably 5 or 6 times. So sorry, Dr. Sagana, I know you're probably tired of me now. And even before it was Dr. Sagana, there was another transplant doctor who I saw her too. So it's been a long time coming, but I think ultimately it was good because you still learn something from them and you still know that they're in your corner for when the time comes, that you know them, they know you, you're prepared, and let's get the ball rolling and get it.
Thank you again.
Thank you.
So I'm Dr. Sagana.
He's the transplant man.
So I just wanted to make a couple of quick comments. One of the benefits with our program is that we do have a transplant center along with the CF program, and we share the same clinic space. So, and through the work with the LLC, over the years, we've partnered, I would say, really well, because even though we worked in the same clinic space, we didn't always necessarily talk to each other, which I think a lot of people can relate to. And so being part of the LLC really got us, I think, closer on the same page in how we want to approach care. And I'll just make one quick comment about this particular process. And so because we work so closely, I'm sitting with one of our CF providers, Dr. Brown, over there. And so we have lots of conversations about, hey, this person is not technically ready, but they have like this potential barrier. And we really feel it would be helpful if they saw you in transplant clinic to at least start these conversations. And so now we're trying to formalize that more. But even beforehand, we would just try to have these conversations earlier. So if you don't have a transplant program like embedded in your hospital system, reaching out to someone. So I see probably over 90% of our post-transplant CF patients. And now we have a program where I'll see all the pre-transplants that are close, either or early. And that's what Ronnie was alluding to. We're trying to work on this like referral process so that when it can be education only, because otherwise, as Ronnie alluded to, it just triggers all these other tests and things like that they don't need. And one of the first things I mention when I see them either in person or virtually is, you don't need a transplant right now, but we need to talk about it. And this has generally already been reinforced by the CF side. So anyway, I just want to make those comments.
And I feel
Great job, Megan.
I feel really strongly like doing this work right now, it's going to get rid of all these crash transplants. And we have so many patients out here that are against transplant because they've seen that. Mm-hmm. And I got to think 75% of that is because we didn't have them ready, right? So we're catching up.
Thank you so much.
Okay. So first off, as I'm loading this up, do we have, other than my two colleagues, do we have any speech therapists in the audience? So I'm just first want to say I'm very excited today because for us from NYP Columbia, for the first time, we brought our speech therapist from NYP Columbia. Probably someone can correct me on this, but in the past on the CF conference, I personally have not heard speech therapists. So I think this is a new beginning to have them, definitely from our side. But if you can remind me if there were previous speech therapists in the previous years, please let me know. But I would like to present Giselle Posada and Gabriela Rodriguez. Giselle Posada, SLP, has been a speech language pathologist for 17 years with a focus in the acute care setting. In her current role as senior speech language pathologist at NYP Columbia University Irving Medical Center, she manages a caseload of patients with varying complexities and provides mentorship for junior clinicians needing training in the ICU, trach vent population, and modified barium swallow studies. Giselle is passionate about trach vent population, pulmonary patients, especially lung transplant, and pulmonary rehab. In 2021, she spearheaded the implementation of expiratory muscle strength training as a treatment modality for patients with dysphagia. Gabriela Rodriguez has been participating as a speech pathologist for 9 years, with the majority of her career spent at Columbia. Her areas of interests and expertise include dysphagia in the critically ill, pulmonary and trach vent population, as well as dysphagia in head and neck cancer and voice restoration after total laryngectomy. In 2017, she led an initiative at Columbia to ensure that all lung transplant patients underwent an instrumental swallow assessment post-operatively, given increased risk of dysphagia in this population. Please welcome Giselle and Gabriela.
Okay, thank you so much for that introduction. So I'm Gabriela, this is my colleague Giselle, and we're very happy to be here to talk about swallowing problems after lung transplant, and also a training modality that we use, expiratory muscle strength training. So we have nothing to disclose. Okay. We have nothing to disclose, so we'll go right into an outline about what we're going to talk about. So I'll start by talking about normal swallowing versus impaired swallowing, and I'll show you examples of what that looks like. We'll talk specifically about the prevalence of swallowing problems after lung transplant and what risk factors put this population at risk of dysphagia. We'll talk about a couple of unique considerations for patients with cystic fibrosis undergoing lung transplant. What is expiratory muscle strength training? And we'll do a live demonstration, and we'll end with a case study. So to talk about first normal swallowing. So swallowing is a complex process involving 50 different pairs of muscle groups. We break it into 3 phases, which is the oral, pharyngeal, and esophageal phase. And from there, we break it into 17 different components. But what we really care about is 2 things, and that's, is the swallow safe and is the swallow efficient? Meaning, can you get food and liquid from your mouth into your GI tract safely without aspirating? And can you get food and liquid from your mouth into your GI tract efficiently without a lot of food getting stuck in your throat? So I'll just show you, and also when we're talking about people with advanced lung disease, we have to remember that the upper aerodigestive tract is a shared space. So it's not just for breathing, it's not just for swallowing, it's not just for speech, it's for all 3. So people with advanced lung disease that may have difficulty coordinating their respiration and swallowing are a particular risk for problem swallowing. So I'll just show you a quick example here of a normal swallow. Is this playing? No? Oh, there we go. Okay, so you'll see this patient is swallowing thin liquid contrast, and you will notice it's a pretty quick and efficient process. So that thin liquid contrast moves very quickly from their mouth through their throat into the esophagus. Nothing is left over in their throat after their swallow, and nothing moves anteriorly into the airway. That's a perfect normal swallow. It's safe, it's efficient. So now I'll show you a couple of examples of impaired swallowing, and these are from lung transplant patients. So this first example is impaired swallow safety. So you'll notice as this patient is swallowing liquids, a good amount of that liquid contrast courses down the anterior tracheal wall. So that's aspiration, and we would call that silent aspiration because she didn't cough. We actually had to tell her, oh my God, cough, you know? So that's silent aspiration, example of impaired swallow safety. Now, impaired swallow efficiency. This patient is also swallowing liquids. So they protect their airway, but notice how much is stuck in their throat after that first swallow. So it's not a very efficient process. They're swallowing multiple times, and this is liquid, it's not food. So you can see there's a good amount left over in their throat. So that's an example of impaired swallow efficiency. So, and in talking about the consequences of dysphagia, people with swallowing problems are at increased risk of pneumonia, respiratory failure, and death, increased risk of malnutrition and dehydration. People with dysphagia are more than twice as likely to die during a hospitalization. They have longer lengths of stay, they have higher inpatient hospitalization costs, and they have a lower quality of life. So now let's talk a little bit about the prevalence of dysphagia in the lung transplant population. Just wanted to play this little man swallowing. There we go. So there are a few studies on this topic, and it's actually become a hotter topic. In the last couple of years, a few different studies have come out about swallowing problems in lung transplant. I picked one just to talk about. So this one came out in 2022, looking at 205 patients in a single center who underwent a bedside swallow evaluation, followed by a modified barium swallow study, which were those examples I was showing you. Of those 205 patients, 170 also went a preoperative modified barium swallow study. So the authors were comparing their pre-op swallow function with their post-op swallow function, and the primary measure they were looking at was, were these patients swallowing safely? Were they protecting their airway? Preoperatively, 83% had safe swallowing, okay, so only 17% had really swallowing problems. Postoperatively, that figure flipped, so 84% had unsafe swallowing after their lung transplant. 45% of patients were aspirating, and 39% had laryngeal penetration, meaning food or liquid goes into the voice box. It's not aspirated yet, but it's high risk of being aspirated. And what they found were the predictors of post-lung transplant aspiration, a couple of things we would expect, like longer intubations, multiple intubations, presence of a trach, but something we also wouldn't necessarily expect. So patients that had VV ECMO at any point during their hospitalization had 6.7 higher odds of having post-op aspiration in this cohort. And when we look at the totality of literature on this topic of swallowing problems after lung transplant, these are some of the risk factors that come up that make these patients a little bit higher risk of swallowing problems after transplant. But I want to highlight just two risk factors on here. So first of all, just undergoing a thoracic surgery where the phrenic and vagus nerves are exposed do make this population more vulnerable to things like a recurrent laryngeal nerve tract injury. So some of these patients may have a vocal fold paralysis or paresis after transplant that can impact their ability to protect their airway. And another factor I'll point out is impaired cough and mucociliary clearance. This is very important. There was one nice study looking specifically at peak cough flow in dysphagic patients and looking at that relationship. And what they found was that patients who had a peak cough flow of under 242 liters per minute, that actually predicted pulmonary complications in those dysphagic patients. So cough strength is quite important for reducing their risk of post-op complications related to aspiration or swallowing problems. Unique considerations for our patients with cystic fibrosis. So there's not a high rate of oropharyngeal dysphagia in these patients, but there is a high rate of GERD and esophageal abnormalities. Depending on what study you're looking at, the prevalence of GERD can be anywhere from 25 to 81%. Some of the characteristics of GERD, physiological characteristics, are increased frequency of lower esophageal sphincter relaxations, decreased LES pressure, altered gastric emptying, and altered esophageal peristalsis. Then exacerbating those physiological characteristics are other factors such as high fat in their diet, certain medications they may be taking, and even postural drainage can exacerbate reflux symptoms. We know that GERD and esophageal acidification occur at a rate of 6 to 8 times higher in children with CF compared to healthy children. And we also know from literature looking at the relationship between GERD and esophageal swallow and pharyngeal swallow function that downstream abnormalities can result in some upstream oropharyngeal abnormalities, such as altered swallow timing, altered pharyngeal bolus pressure, cricopharyngeal dysfunction, and laryngeal edema and inflammation, which can all impact swallow function. So Giselle and I spend a lot of time thinking about how to help lung transplants with swallowing problems. So turn it over to her.
Thank you. Thanks, everyone. So we started using EMST at our center in 2021. We brought this treatment modality. There's a lot of research behind it now showing positive outcomes. So what is expiratory muscle strength training? So this is expiratory training for the muscles of expiration, so strength training. We use a pressure threshold device that it's calibrated. It has a spring-loaded valve, and we set the trainer and the load based on the patient's MEP, the max expiratory pressure. So over time, initially this was created to really target cough. And over time, it showed positive outcomes in the muscles of the larynx, the vocal folds, the soft palate were also engaged during this pressure threshold exercise for the expiratory muscles. So this is measured using centimeters of water pressure. So just to give you a reference, so speech requires 5 to 10 centimeters of water pressure, cough requires 100 to 200, and the Valsalva movement requires 2 to 300. So these are the trainers that we're using at our center. There's 2 of them. One of them is for lower threshold, so it starts at 0 to 75. So this is a great one for patients, let's say, just coming out of the ICU that are very weak and deconditioned. Maybe even patients with a trach can use this as well. And then the EMST 150 starts at 30 and goes to 150 centimeters of water pressure. And there's been a lot of research. This EMST started about 20 years ago is when it was developed, and there's been so much research showing positive outcomes in maximum expiratory pressures, cough strength, muscle activity in the submental suprahyoid muscles involved for swallowing, swallow safety in some diagnostic groups, and quality of life in some patients, some patient populations. So the basic protocol for this, it's the power of 5. So you would do 5 sets of 5 breaths each day for 5 days a week for 5 weeks, and then you rest for 2 days of the week. And it's generally set at 75% of their MEP, that's the training load. But for patients, let's say with COPD or ALS, we would, or even patients coming out of the ICU post-transplant that maybe still have some chest tubes, we would train at 50% of their MEP. And we also ask the patient their effort, how hard they're working. So it's not only, you know, sometimes I have patients that I set it at 75, but once we get to, let's say, the second or third set, they can't break that seal anymore because they're fatigued. Maybe they need a longer rest break. So we kind of troubleshoot with that, or we just need to change their training load to less than 75%. And each week we recalculate the MEP, and then we increase their load depending on how they do. And this is mainly for inpatients. So these are post-op lung transplant patients with dysphagia. We start them doing this. So contraindications for using this treatment modality, the main one is really Valsalva. So if the patient is not able to generate a Valsalva maneuver, then they are not candidates for the EMST. Patients that are not able to perform in PFTs for whatever reason, then they can't do EMST either. Uncontrollable reflux, of course, because when you are doing this exercise, you are generating that intrathoracic pressure, so we don't want to exacerbate that. And then special considerations, there's a few on here. Lung transplant is one of them. We do get clearance. We in-service our teams, our nursing staff, so they are familiar now when we walk around with this device. They know what we're doing. The patients also do them on their own, but we do get physician clearance first just to make sure that we can proceed and do this exercise with the patient. So some other respiratory devices, these are great for different reasons, but they're not for the purpose of strengthening the muscles of expiration. Often we start with an incentive spirometer just to see what their inhale is like, because if we have somebody that has very shallow inspiration, they're not going to do so well with that forced expiratory strengthening device with the pressure threshold. So sometimes we may start working on that. You know, let's really slow down your breathing. The incentive spirometer is great in the beginning just to get a gauge of that. Then we have the breather. which a lot of COPD patients I know are recommended to use that, but it's not a strengthening device. And then the other two at the bottom, the aerobic and the acapella, are more for the mucosal layer clearance. So I wanted to highlight one study that looked at the expiratory muscle strength training, the effects on peak cough flow for children and adolescents with cystic fibrosis. This is a pretty strong study design. It was 30 patients that were randomized as a training group and then the sham group. The training group trained at 30% of the MEP, and the sham group trained at the lowest pressure on the device, which was 5 centimeters of water pressure. Their protocol was different. It was a little bit more intensive. They were doing this twice per day for 5 days per week for 6 weeks. And the main study limitation here is that the device that they use for EMST only went up to 20. So it really limited patients that were able to maybe train at a higher load. It limited them from that because it only went up to 20. But they found some really significant gains. The training group, they showed gains in the peak cough flow, in the MEP, the treatment burden, digestive system, and quality of life, and then a significant improvement in MIP and the 6-minute walk test to about 48 meters in the training group. So for the live demonstration, I'm gonna have Gabby demonstrate here. So we use a manometer, so that's to get their max expiratory pressure, and then we use a peak cough flow as well, just to get some objective baseline data. And from what Gabby said, that other study, we really want patients to be at least 242 liters per minute on their cough to avoid some, negative related pulmonary sequela from aspiration or dysphagia. So after we get their measurements, we'd set it usually at 75% of the MEP. So Gabby's going to show you what this looks like.
It's quite simple to use.
Okay, so that's the sound that you want to hear when you're breaking the seal. So we usually want the patients to wait 15 to 30 seconds between each rep, just to give the lungs a chance to recoil. So they will do a total of 25 of that, so the 5 sets of 5. We usually like to have a family member or somebody there to also learn about the device. We educate the patient quite a bit on using the device. We try to get to them as often as possible in the acute care setting, which can be challenging at times, but we are doing it. All right, so just one case study. This is a 23-year-old double lung transplant recipient. She was intubated for 6 days, had VA ECMO for 3 days. She did have chest tubes in place for several weeks, several weeks. We did her first fees. We do fees thanks to Gabby's advocacy a few years back. So we do an instrumental assessment on all our post-transplant patients. So she had hers on post-op day 9. It showed that the left vocal cord was not moving, and she did have deficits in swallow safety with the thinner liquids. So the recommendation was a regular diet and moderately thick liquids. So EMST started 2 days after that. We trained between 50 and 75% of the MEP, 5 days per week. Post-op day 15, she had her second fees, and she was able to return to a regular diet. So what I want to highlight, though, is if you see post-op day 1, the baseline measurement was 160 liters per minute. So that's pretty low. That's, we're very worried when somebody has, and we actually see that pretty often, that their cough is at such a low velocity. And her MEP was 30, and then it increased the peak cough flow to 340 and then to 400. This is once she was already discharged at home. And so I wasn't able to get the last MEP for her, but she got close to the peak cough flow for normal range for her age. And then this is a direct quote from her. I love how with EMST, I was seeing immediate results within the first week of me using it. It's small and relatively simple to use. With instruction, it made me feel as though my recovery went along faster than it would have otherwise. So with that, this is our bibliographies, and thank you for having us.
Thank you so much. Any questions?
My name's Justine. I'm from DC Children's. Did you guys control in your education for any postural considerations or education on like utilizing pelvic floor activation so we're not experiencing incontinence while you're doing expiratory muscle training?
That's a great question. I mean, we do definitely emphasize having good posture while doing the exercise, especially for our ICU patients that often, like, it can be a struggle for them even to just sit up and have that good trunk support. But pelvic floor is not something we've explored. We haven't had that happen. Anecdotally, I don't think we've had that happen, like patients complain of incontinence while doing it. But that's a great consideration.
Cool. Yeah.
Raul Villacruz from University of Iowa. Great talk. I think it was excellent. Couple of questions. We know for sure silent aspiration is a big deal post-transplant. But before going to that, so it seems that the training of the expiratory muscles is physiologically is helping the upper airway muscles. But my biggest interest is of course lower airways and small airways. Have you had any experience or any studies done on using expiratory muscle training and improvement of, airway clearance? Anything related to that? So that's one question that I have for you. And the other one is, what are your thoughts on people who need to use a CPAP machine at night, especially, like patients with a CPAP? How could this interfere with your training?
Yeah, those are great questions. So the first one, EMST for the lower airways, for airway.
Yeah, if there's any impact in the airways specifically.
Yeah, so I mean, in the body of research that exists on EMST for swallowing problems, it does show improved airway clearance, but we're talking more specifically about like food and liquid that gets into the airways. So specifically regarding lower airways of secretions, I could get back to you on that. I'm not sure off the top of my head. And the question about CPAP is great. So it is the timing of doing EMST is important. So you want to do it at a time at least 30 minutes, if not an hour after eating. So also if it's a patient on tube feeds, you have to wait 30 minutes after tube feeds to reduce risk of reflux-related aspiration or aspiration. CPAP, there's no restrictions on that, but I would probably wait at least 30 minutes after CPAP before doing something like this.
Thank you. Yeah. I would just add on for the expiratory airway clearance for the lower airways, it's just going to be dependent on the time of exhaling too, so that if you're actually utilizing that device long enough to be generating a backflow, so you're getting collateral ventilation at those airways, yeah. And the amount of pressure that you're generating as well.
Hi, I'm Bridget. I'm from Loyola Medical Center in Chicago, the lung transplant program. And we actually implemented standardized fees in all post-lung transplant patients probably like 4 years ago. My question is how do you have like a standardization of how often you follow up with the fees, or is it based kind of on the patient's progress in therapy?
I think it depends on the patients like her, that she very young, yes, has had a left vocal cord paralysis, but she only had 1 or 2 instances where she did aspirate. And we started doing EMST with her pretty quickly. I mean, she had 3 chest tubes in, and we were still able, we trained at a very low threshold. I think she was at like a 20 or 23 to start with. So that's pretty low, but it still made real big gains for her, made a difference. So with her, I repeated her fees just a week after. Sometimes if the dysphagia is so severe that they're aspirating all the liquids, I absolutely want to see that person the next day and start him on EMST, start him on other exercises, and then maybe repeat their exam maybe 10 days instead of 7. Sometimes we may repeat it 5 days after. It really depends on the dysphagia that we identify. But if it's somebody that I'm going to wait longer with, I definitely communicate with the team because, they want to get this patient out, right? Especially somebody that's walking. And the one example that we showed with the efficiency issues, that patient was in the hospital for like 3 months. And his dysphagia was pretty significant. He also had a lot of like motility issues that he developed after, but he's somebody that, we waited longer. We did more therapy with him before doing the exam. Because for these patients, they go through so much inpatient, I'm sure before, but also after. We really don't want to test them too often and then not able to advance their diet, because that's also very frustrating for them. So that's a great question, because sometimes it's a hard balance, to judge once to do the next exam. But
Thank you. And then one quick other question. What about like those patients that are discharged earlier than the 5 weeks? Do you guys have any sort of like follow-up outpatient for those patients? Because I have lots of patients who are discharged on a dysphagia diet.
yeah, so we set them up when they get discharged, when we know when they're getting discharged, we set them up already for outpatient. There's an outpatient referral. Gabby works in the outpatient part as well, acute and outpatient. We set them up with an appointment. By that time, they're very familiar with the device, so we just tell them to keep doing it every day like they have been, and then they come back and do another exam, the modified barium. So sometimes in a few weeks, sometimes we may say like a month's time. Yeah.
Thank you.
You're welcome.
And I really apologize. Can we hold off on the last two just so we have time for our last speaker? And then anybody that wants to stay after can ask all our panelists any more questions they want as well.
Thank you very much. So last, I would like to introduce Jennifer Liu. She's a physical therapist. Jennifer graduated with her DPT in 2007 from New York Institute of Technology. She has spent her career working at NYP Columbia Hospital as a senior physical therapist with adult and pediatric patients and their families in the inpatient setting. She served as the lead pediatric physical therapist at the Morgan Stanley Children's Hospital Cystic Fibrosis Center from 2010 to 2013. Jennifer holds the pediatric, she received in 2020, and neonatal therapist in 2022 certifications. Her specific interests lie with the neonatal population. And here is Jennifer.
Thank you so much, Marcin, for the introduction and this opportunity to present today. Oh, wait, no, that's not me. I think I have to go to my name. Wait. There we go.
Able to escape.
Yeah.
Go here. Thank you. Okay, so my section of this talk today is to present the patient's perspective through lung transplant. I have no disclosures. And just a little bit about where I'm from. So I'm from New York Presbyterian. I work at the Morgan Stanley Children's Hospital. That's in New York City in the state of New York. Our children's hospital has a designated CF center, but we currently do not have a pediatric transplant center. We are across the street. We have our adult hospital who has an adult CF center and our transplant center as well. So the goals of this presentation is for our patient interviews is to talk about and gain some insight on the patient's perspective on how they felt like they were prepared for lung transplant, and also to learn if they felt that undergoing lung transplant had impacted their quality of life in any way, and also to gain some information to see how we can better help further prepare our patients who are undergoing or in that that window of needing a lung transplant at some point in their life. So how did we recruit our subjects? So we had identified 5 patients as candidates through our pediatric center. They were known to our CF center, had cystic fibrosis, and met the criteria for lung transplant. So we had asked them to participate via phone call. Of the 5 of our patients, 3 of them had agreed to our interviews. 2 were done via in-person video recordings, and 1 was done agreeable through voice recording. Some of the questions you'll see in the presentation were not asked to all 3 of our participants, just reviewing very respectful to where they kind of were in their current medical status. And these interviews took place through April and August of this year. Okay, so some information about our subjects. So patient A, during the time of the interview, was 21, had a double lung transplant in 2020, and was 18 years old at the time of transplant. Patient B, during the interview, was 18, had a double lung transplant in 2017, and was 15 years old at the time of transplant. So patient B was transplanted at an outside pediatric center, and patient A and patient C were transplanted in our adult center. And then patient C was a female who was 20 at the age during our interview, had a double lung transplant in 2019, was 16 years old, and at the time was relisted in June for a second lung transplant. And just a nice little update about patient C. She actually got her second lung transplant a few weeks ago. Okay, so these next two slides I just provided listed out in case anyone was interested in doing something like this at their center to try to improve their transplant preparation process in any way. The list of the questions that we had asked during our interview. And then so now we'll just get into the interview questions and their responses. So for question 1, we asked, what did you expect the immediate post-op recovery process to be like, and how did the team prepare you for this? Did your experience match your expectation?
Because when I think of a transplant, I think of something big, something painful, but also like life-changing. And, you know, if it's life-changing, obviously you have to go through some pain. So yeah, it did match my expectations, and I think, you know, as much as it was painful and hard, I think it was just a great thing that I went through.
Awesome, thanks.
I'm not gonna lie, I didn't expect it to be anything like what I experienced. I expected me to just push through everything realistically. I mean, I did, but I wasn't expecting to be as much pain I was in.
Oh, so you were in a lot more pain than you thought you would be.
I didn't think I was gonna be in any pain, but yeah, it was according to my dad, because I don't remember it that well, but according to my dad, it was crying a lot. So
Very crucial. Like, very extremely important for me to understand and get through.
And how do you think that the team prepared you for that?
Just by talking to me a lot. Like telling me like this isn't gonna be a walk in the park after. Like, I think that speaking to me before going through it helped me mentally prepare myself more for the aftermath.
And did you feel like if you had someone who went through it like you did beforehand talking to you, it would have made a difference?
Yeah.
And did your experience match your expectations?
Yeah.
Okay, and then for our second question, what was one aspect of your life that you were looking forward to being different after transplant? Did this change end up having an impact you? Sorry, did this change end up having the impact you thought it would have? So responses from patient A was, I was looking forward to being able to walk around and be free without oxygen or needing breathing machines. Patient B said, I thought my relationship with my mother would change since I'd be more independent, but it did not. Our third question was, is there any part of your life prior to transplant that you missed? And we're specifically trying to gain some insight into their airway clearance regimen. Patient A said no. Patient B said, I missed the vest, but not manual chest PT. Question 4, what was something during the acute recovery phase that surprised you?
Everything went really smooth for me. And like I said, everything kind of happened the way I expected it to be. I didn't have any issues like through my healing time, so I think everything went good.
I guess how fast I recovered. Well, actually, not really. I'm just like that. But I guess that was a bit of a surprise because I wasn't expecting to be that fast with it. The only thing that obviously I had to stay home because they had to make sure. But in terms of like recovery, even the doctor was like, "Dang, you recovered pretty fast." I was just like that. I'm just a mutant. Heal fat.
The pain that I was physically going through.
It was more or less?
More than I thought it would be.
And was it just your surgical site or was it everywhere?
Surgical site.
And did it get worse when you moved or better?
Better.
Better when you moved. Was that surprising?
Yeah.
Question 5. Were there any aspects of transplant recovery that were easier than you had anticipated?
Healing phase of it was a little bit better than I expected it, just because at first I did go through a lot of pain, but it wasn't the pain kind of that I was expecting it to be, like a really big pain. It was more like, a pain when you get surgery, but then after a few days or weeks, it just goes away and you're back to like normal.
Stuff. That was actually really easy, especially the treadmill, which I don't know why, but the treadmill was like so easy. It's probably easier. Well, obviously it was easier than before.
How quick I was able to bounce back post-transplant.
Like physically?
Yeah.
What about mentally?
Yeah, it was a way for me to work through everything.
And our next question, what part of your life do you wish you optimized before transplant? What did you do to prepare for transplant? Were you participating in physical therapy, going to the gym?
Do physical strength just because at the time I was very weak with my physical activities and everything. So I feel like if I would have been stronger with my body, the healing would have been a bit easier.
My weight, but I'm working on it now, so. But yeah, before I wish I would have worked on it a little more, so I got into the habit, I guess, of not being lazy.
Endurance. Well, I was already working with physical therapy prior. So I feel like my endurance was as best as it could be, given the circumstances.
Question number 7. Before your lung transplant, did you feel that your CF diagnosis was isolating? Did that change after transplant?
Yes, I did feel like that at times, just because with all my treatments and nebulizers and everything, it just didn't really give me a life anymore or really time to do anything outside. And then with oxygen machines and everything, it felt hard.
Was never home, actually. I was always in the hospital, so pretty much I didn't have to do anything. And now that I'm able to do stuff I want to, so I will, no matter what. Because that's what I do.
Your transplant.
No.
You still feel isolated?
No, I never felt
You never felt isolated?
No.
Do you think that has a lot to do with your upbringing? Like your mom made sure that you were involved in things, and
I made sure I was involved in things. I made sure I knew what I had and what it meant.
Question 8. If you could give advice to another patient with CF getting worked up for transplant, what would you say to them?
Well, I would definitely tell them to not give up and to not you know, regret anything that's happening in their life right now. I think transplant is like the best option that they have out there, and you know, it changes your life in so many ways that you can't really explain. So just keep going and keep going with the treatment, and everything's gonna be all right.
What would you say to them?
Got this. Got this. You finna make it. Cause we just like that. We just different, okay? You don't have nothing to be afraid of. I was afraid too, but after you get done, like when you recover and you start doing the recovery and you don't feel the pain anymore, that's when your life is gonna start. And you're going it's gonna change you. You're gonna be a whole different person, basically.
To be mentally strong and to take it day by day. And pain is temporary.
Question 9. Is there anything you could change or improve about your post-transplant journey? What would it be? Patient A, I wouldn't change anything. Patient B, be less lazy from the start. Patient C, nothing. I have no regrets. Question 10. If you could go back in time to when your CF team presented the possibility of getting a lung transplant, would you still go through with it?
Yes. I actually, even though I don't really like medicine and all that, I would say I guess it's better to be able to do stuff than to not do stuff.
Question 11. After transplant, you were faced with COVID-19. How did it feel to have this new virus knowing you just got new lungs? Did you think you would have had a different recovery before the transplant?
It was traumatizing. I was scared for my life because I just had gotten through this big surgery that kind of was to change my life, and the fact that, you know, this virus was out there for a long time now, and it did damage to like so many people. I was scared that, you know, I wasn't gonna make it, but you know, here we are.
And do you think you would have had a different recovery before the transplant?
Yes, I think without the transplant, it would have been a worse recovery.
Question 12. How did it feel to need to travel out of state for transplant care? B. At first I hated it, but then it was okay. 13. Before you had your transplant, you were on ECMO. Do you remember anything about your journey while on ECMO?
I was sedated for partially the majority of it. But from what I can remember, it was great walking with it. And realizing I was capable of that. It made me feel mentally strong.
Okay, and for our last question, how did it feel going from the children's hospital where you were familiar with the providers to the adult hospital for transplant and recovery?
I feel like it was great. They're very motivational. You can see that they want you to get better.
The adult side.
Yeah.
Versus
post-transplant. No, both. Like they just pre-transplant, they want you to be as strong as you can be, and push you as much as you mentally can withstand. But post-transplant, they just want to push you to reach that goal that you set for yourself, like to prove to yourself that you can do it.
Okay, so in conclusion, we've seen that our patients with lifelong chronic illness demonstrate continued resilience. We also learned through these interviews that too much pre-transplant education doesn't exist. It's important to cover all aspects of the transplant recovery while we're educating these patients. Emphasizing the importance and the adherence of getting into a good exercise regimen before transplant is really important, especially as all three of our patients had really echoed during their interview. And the other thing that I want to highlight is that they really all kind of spoke about after their surgeries the pain that they experience. So really making sure that our patients are getting that they have adequate pain control options should be in place, and especially utilizing those specialized pain management teams that we have in the acute setting postoperatively. In the future, these questions may better reflect a patient's transplant experience if asked during their acute recovery phase, because like during our interview sessions here, they were asked quite a bit of time after their initial surgery. I would like to acknowledge some of my wonderful team members who helped get this presentation together and conduct these interviews, which is Barry Stein and Denise Gibbs. And a real special thank you to our patients for participating and sharing their experience in their lung transplant journey. Any questions?